us tonight for Illinois Bone and Joint Institute's 69th virtual YMCA Education Series program with the North Suburban YMCA. My name is Karen Brownlee, and I'm a personal trainer and the adult program coordinator at the NSYMCA in Northbrook, Illinois. This evening's presentation, entitled Understanding Rehab and Recovery After Hip Replacement, is being recorded so that you will be able to revisit it again. Please feel free to tell your family and friends about it so that they too can view it once it is posted on the IBJI and NSYMCA websites. If you're here this evening, hip replacement is likely something you or someone you care about is considering, and you know the value of understanding the rehabilitation and recovery process following surgery. Studies show that patients who actively participate in structured rehabilitation after hip replacement regain mobility faster and experience less pain than those who do not. Recovering from hip replacement surgery is a journey that requires the right care, guidance, and rehab. Tonight, Illinois Bone and Joint Institute's Kurt Hutchinson, PT MPT, will take us through what to expect after surgery, essential rehabilitation exercises, and tips for a smoother, more effective recovery following hip replacement. Kurt has been a physical therapist for IBJI for the past 23 years, and in that time has held a variety of roles, including staff therapist, facility manager, and he is now a regional manager. From 2016 through 2023, Kurt led IBJI's Ortho Health program, where he collaborated with therapists throughout IBJI to integrate care for ortho health patients and create individual plans in a variety of disciplines to have a positive long-term impact on their lives. Kurt has worked with athletes in a variety of sports, including baseball, basketball, football, triathlon, and golf, and at all levels, from Little League to collegiate to professional. Kurt assisted athletes with foot and ankle rehab and orthotic fabrication at his alma mater, Northwestern University, where he received his master's of physical therapy. More recently, Kurt has been working with patients to help them manage chronic and persistent pain. In addition to pain management, Kurt's specialties include sports medicine, shoulders, knees, feet, ankles, and of course, our topic of discussion tonight, hips. During Kurt's presentation this evening, you might find that you have questions for him, which he will be happy to address at the end of the program. Simply type your questions into the question section on your screen, and I will receive them and relay them to Kurt immediately following his presentation. I do ask that you please keep your questions general, as he will not be able to address individual concerns without individual consultation. If you do have self-specific questions, please contact Kurt via one of the options that will be listed on the slide shown during the Q&A portion of the program at the end of his presentation. One last thing before I return the evening over to Kurt, please mark your calendar for our next IBJI and YMCA Education Series program on Wednesday, November 19th at 7 p.m. Dr. Nirgwana Thala will help us understand lumbar spine conditions. Thank you again for joining us tonight, and thank you, Kurt Hutchinson, for your time and effort in putting together this program to help us understand rehab and recovery after hip replacement. Kurt, please take it from here.
Okay, let me get my screen up and we will go. How do we look? Karen, is that okay?
Yep, it looks great, thanks.
All right. Okay, well, thanks for having me back, everyone. I enjoyed it last time. We were able to come through in, minimize myself here. I don't need to look at myself while I do this. We were able to do the total knee several months ago and had a really good response. So we thought coming back and doing the total hip might be a good way to start to close out the year. So I really appreciate being back. Had a good time last time with this, and I look forward to talking with you about this tonight. So there's a few things I want to be able to cover tonight as we go through this. If you're thinking about surgery, I want to think about what that process looks like for people. A lot of people have pain in the hip. I've got pain, but I'm worried about what this surgery is going to look like. What is this going to look like for time, for recovery? What does my pain look like? So I want to talk about a little bit about the preoperative and then mostly the postoperative recovery, what that looks like after having a hip replacement. Try to answer some common questions that people have and explain how we get back to living and moving better, because that's why we do these things, so we can continue to move and live better. So I want to set some expectations here for what this is going to look like, because these are the common questions that people are going to ask me. What's this hip going to look like? What's this scar going to look like? How big is it going to be? How long is this hip going to hurt? How long is it going to be swollen? Is it always going to be puffy like that? Totally fair questions, but ones that we can give you some general answers to. How long till I can get back to walking again? When can I get back to my chosen activity? Golf, pickleball, driving, travel. There's some individual basis to that, but we can give you some general ideas about what that looks like. And then ultimately, what can I do when I'm done? What are my ultimate limitations? Some key principles I want you guys to keep in mind tonight: that rehab is not something that is done to you. It's a collaborative process that you're actively going to be involved in, right? We want you to be able to come to us, talk to us about what your life has been like. How are you moving? What's your pain and range of motion before surgery? Your preoperative status, how you look before surgery, greatly determines what those first few weeks postoperatively look like. We're going to take into account what your goals are. Where do you want to go? What do we want to get you back to doing? And develop a pathway that's going to help you get there. Early on, activity is important. It's not going to be sitting in a chair. It's important to get up and start standing. And then consistency is the key to success. We don't need to do fancy exercises or anything particularly anything that's particularly challenging, but we do need to be consistent. We want to get to walking early. Starting walking early is one of the most important things you can do. Walking will get you a long way. And then for everybody, you'll have some post-op restrictions. We need to get back to managing those post-op restrictions as much as possible. Making sure that if there's limitations the physician put on you based on the kind of hip that you had done, we're going to make sure we do those things effectively. So managing those post-op restrictions. Why do therapy? Why do we get involved and talk about physical therapy so much in the process? The surgeon, look, is doing a lot of the hard work. They're getting everything in place. It's us to help you manage all these things after surgery, help manage the pain. If you just sit around, your pain's going to be greater. We need to make sure we manage that pain. Getting up, moving at the appropriate level will help manage the pain. Getting up and moving means there's less risk of clots. You're going to start to get your strength back, so you'll have less complications down the line. Getting up and being active means we're going to have a better balance. We're going to work on decreasing your risk for falls. That in turn is going to improve your strength and function as you build that strength back up to your new level. It's going to get your recovery better. And then long term, if your hip is bad, you're not going to function very well. Your cardiovascular fitness is going to start to decrease, and it's going to cause a lot of long-term issues. So making sure we're getting you back to moving and functioning at a good level is so important for these activities. So that's where we want to get you to. Most of all, we're here to be the experts to help guide you through the recovery process. The physicians, their teams, our teams in rehab are all going to work together to guide you through the process. One of the things I always tell my therapists are, we may have seen 100, 1,000 hips. For the person that's coming in, it's the one hip they're going to do. Hopefully two, no more than two. If we can keep it to that, it's good. But we want to make sure we do that. We're there to give you perspective. Hey, does this look normal? Is this supposed to look like this? Is this normal to have pain like this? I have this weird shooting pain from time to time. Is that normal? And the answer to most of those is, yeah, this is normal. We'll talk about some of the things we want to keep our eyes open for, but we're there to give you that perspective. Am I doing too much or not enough? Let's talk through your activity. What's your day like? I'm doing my exercises, but I also went and stood for 3 hours. Well, that's probably too much. I'm not telling you it's too much. Your hip's going to tell you it's too much, right? So based on all that information, we're here to just guide you through the process. The hip is a very stable joint. It's very strong. And when we get these done, people do very, very well. But it's important to just kind of taper that activity, slowly build up that activity as we go along, and not try to do too much too early. And you'll have a much better response. In the hip, before surgery, people have a lot of different kinds of pain. Pain in the front of the hip joint, kind of right at the front of that pelvis. Sometimes that pain is on the flank or on the outside of that hip, kind of on that hip pointer people will talk about. That's often more tendon and bursa and muscle pain. In the front, that's often a little more joint pain. In the back, that could be coming from muscles. It could be from your low back or your SI joint, any of those things. All that to say, not all of those things are going to be the same. Not all the pain is going to be gone on day one. That doesn't mean there's a problem. A lot of the joint pain is going to go away because, the joint is now metal and not bone. So the metal doesn't have any nerves in it. But the tissues surrounding the joint are still going to be sore, especially those first few days. The muscles, they're going to be adjusting to that new hip and the post-op process. There might be some nerve and low back pain that we have to get you used to over time. Oftentimes we've compensated for that hip in one way or another, starting to lean, work around this hip joint. And all that stuff has to just settle out over time. So giving the body a chance to slowly adapt over time does take a little bit of time, but we'll guide you through that process. What's that pathway look like? I think it's important to have a preoperative discussion. When is the right time to have surgery? And that's a great discussion to have with surgery. The general guidelines that I'll tell you most of the surgeons have told me and will probably tell you is when you start adapting all the things in your life around the hip, it's time to start thinking about it, right? If you find yourself saying, I'm not going to go here, I'm not going to do this, I can't enjoy this, I can't take this trip, I can't go visit this person, then it's time to start thinking about that, because you're making more and more adaptations for something we can address, right? You will know when it's time to do those things, right? And you can have that discussion. As a therapist, I am all for keeping your joints as long as possible, right? But at some point, it starts to become diminishing returns, and it's time to start addressing that. And the surgeon can help you with that decision, but that's when you should start thinking about those things. If you happen to do surgery, you're going to be at the hospital or the surgery center, and then make sure you're before you leave that you're ready and safe to go home, wherever that's going to be. For most people, that's going to be home. You're going to be going home after surgery. They're going to get you up in the hospital. They're going to make sure that you're safe to get up out of a chair, to take a few steps, get where you need to get into your home. If you have a step to get into your home, they'll make sure you can do that step to get into your home. Before surgery, oftentimes we're having people have pre-op appointments with the physician team or our physical therapists, and at which point, if there's any things you're going to need at home, hey, I can't get upstairs, so I'm going to need a bed on the first floor. Again, rare, but does happen. Most of the time, it's a little reacher, so if I'm not allowed to bend forward, a little raised toilet seat, a few simple things like that to make sure you're safe if you have some hip restrictions. But most people are going to go home. Some people are going to have home health at home for a little bit. They're going to have a therapist come to the house for a little bit. Other people will go directly to outpatient therapy. They're feeling good, they're otherwise active, and they're going to come over to outpatient therapy. Some people, though it's rare, they'll go to a skilled nursing facility, right? A place where either their medical needs or the lack of help at home means they might need a little more assistance before they head directly home. This doesn't happen all that often, but it is available for those that might need it. Let's talk about the hip joint itself. So when we talk about the hip, this is on the left side of my screen here, you'll see that hip joint. The big top of that, this is like half of your pelvis. So the very top of this picture is that hip of the pelvis. So if you put your hands on your hips, like I'm a little teapot, right? That's the wing of the ilium. That's the ilium or the wing of the hip, or the wing of the pelvis, excuse me, up there. As you come down, this is the hip joint down in the center here. You'll see the socket, or what we call the acetabulum, and the femoral head here. That's where that hip joint articulates or moves back and forth to allow us for that motion. It's a nice deep socket with a big, strong joint. To the outside here, two other things that you want to take up. You have this kind of L shape that comes down. That's your lower leg bone. That's the upper leg bone. That's your femur. On the outside, we have the greater trochanter, which is and I point that out just because I'm going to show you where a lot of those muscles attach. Sometimes when we have some pain on the outside of that hip, we'll often feel it in those areas, in those muscles in the bursa. And that's why pain in the front of that hip is often so much more anteriorly in the front of the pelvis, because that joint is in there deep. People often will come in and say, well, where's my hip out here? Nope, the hip's in there deep. What you're feeling is the outside of that greater trochanter, or the edge of that femur on the outside. And there's a lot of muscle and tissue around that. In the upper right of the screen, you'll see, if we've kind of taken that hip out of its socket, you'll see the hip joint there. So that's that same ball and socket with that deep hip socket. And on the outside, there's a lip, or a labrum, we call that. But that's where that is. On the bottom, what you'll see is all the thick ligamentous structure. That's another thing that gives that hip its stability, is we've got this thick capsule that surrounds that hip joint as well. Now, to get down to the hip and do the surgery, we have to cut through that capsule, and so one way or another to get to there, so to replace that joint. But this is what the structures kind of look like. And I think it's always important to understand what are the structures we're dealing with. Now, here we put all those muscles are in the picture now. On the left side, you see the glutes, the big gluteus maximus, the posterior muscles here. As you peel that away, on the right side, you'll see some of those lesser hip muscles. And you can see the gluteus medius and the minimus and all those muscles. You see how many of those muscles attach out onto that hip. So there's a lot of stuff that attaches onto the hip there. And this is where, if you've had a hip that's been giving you trouble for a while, or some weakness, we have to build all that strength back up to help give that hip the long-term function that it needs, so we can walk level and steady and have good balance. All these things are many of the things we'll work on post-operatively. But that gives you an idea of kind of what the structures are that we're talking about. What happens when we have hip arthritis? Well, here's the hip joint showing a joint with a little bit of arthritis. And what we're really showing you here is, over time, the surface of that femur, the surface of that femoral head is this nice white surface there, nice and smooth, kind of like a cue ball, I've often said. And that surface, being as smooth and as perfect as, can just handle lots of rotation. It moves millions of times across the course of our life. The surface of it, what we call the articular cartilage, right? And that's like the hard enamel surface on the outside. And what that does is allow for that surface to bear that weight and that motion so many times. As we start to have arthritis in the hip, we start to get a breakdown of that articular cartilage, and we get down to that bone underneath. And that's what you see here, little redness, inflammation, and irritation under there. So just like when the enamel in your teeth breaks down, it starts to become painful and a little irritable, right? When that happens, this is what you'll start to see. Okay, here's what that looks like on X-ray. On the left, you can see the femur and the femoral head here, and then that socket. And in that socket, you can see there's a big, nice C-shaped space around there. There's joint space, right? That's what we see. And the reason, it's not that there's space there, actually. What you're seeing is the articular cartilage doesn't show up on the X-ray. So that bearing on that articular cartilage sits right there. On the right, you'll see when that articular cartilage is gone, now that joint looks like it's kind of collapsed down on itself. And it is, in the sense that articular cartilage is no longer there. And when people say they're bone on bone, that's what's really going on. There's always bone on bone. The difference is you don't have that nice protective articular cartilage, right? That cartilage, which just literally articulates or moves on each other there. So that's what you start to see in that breakdown. And that's when you start to see people having a lot more pain, difficulty moving, all of those kinds of things. When they go to do a hip replacement, this is what they're going to do. They're going to replace that socket and that ball with the hip. Again, there's many versions of this hip. I am not going to go into all of those because I am not qualified to do so. But essentially, you're just replacing those surfaces that have gone bad or had wear on them, and with a new surface, right? We've got this now new ball and socket and metal that sits there, and plastic, whatever surfaces that are there. That's what that's going to look like. On the left, kind of just a representation of it. On the right, this is kind of how that shows up on X-ray. You've got that stem that runs down the center of that femur and gives you stability in that joint. So at this point, we've got surgery. We're going to be outpatient or have a one-night stay. We'll go home and do some home health PT, or we'll go home and do no home health and just go right to an IBJI PT clinic if that's the case. Post-op care, what do we need to think about? We're going to look at that incision. We're going to monitor for redness, for any itching, any signs of infection. Again, it's rare, but it can happen. We will get some redness. We will get some itching. It's normal for that to happen. If we get a lot, we'll make sure we're not reacting to anything, right? If we're getting a lot of redness or that redness is spreading, then it's good to make sure we're aware. Like if we start to see more and more redness over time, well, let's take a picture, send it to the doc, talk to the team and go, is this normal? Make sure we don't have any risk of infection. I'll show you a picture of kind of what that hip is actually, those incisions actually look like as well. Some swelling is normal around the hip, and that can take a month or two to go down, but sometimes we'll feel a little puffy around the outside. You'll feel some pressure there, but that usually dissipates fairly quickly, especially as you go along. Some bruising's also there, right at the hip or down the leg a little bit. Remember, bruising is just the body breaking down a little bit of blood that was underneath the skin there. There's a substance called bilirubin, which is my favorite name in all the body. Sounds like a New Orleans jazz musician, but bilirubin is a substance that breaks that down, and that's what gives us bruising. So the liver just breaking those products down. So bruising's normal, and since it's blood, if it's just kind of trickled into a different area, just got pulled down with gravity, you'll see some bruising down the leg a little bit. Again, totally normal stuff to have. As far as pain goes, most patients rely on some pain medication the first few days, post-operatively, and then that tapers down fairly quickly. Most people will still have pain medication at night for a little while longer. And the reason for that's important. We want to make sure you get some sleep. If you're up all night with pain, that's not a good place to be. Getting good sleep allows you to recover better. Eating well, getting good nutrition preoperatively and postoperatively is really important. Now, if we're not getting enough food to fuel us, if we're not getting enough protein to allow our body to use that protein to heal us and build back up, recovery is going to be a little slower. So taking care of yourself pre and post operatively is an important part of this. So we want to make sure we do that to the degree we can. So, and sometimes pain medication or just natural appetite after surgery, after anesthesia, or just not feeling it. Some people don't have a ton of appetite, but if you can get a good meal in, have some protein, those kinds of things, most people will tell you that does help that recovery continue to move forward. There are different approaches to the hip over time. The back approach or posterior approach is the one that was common for many, many, many years. And it still is done. And then you have this lateral approach, and there's variations of this. We'll do the mini lateral, the anterior approach. There are many different kinds of these. Talk to your doctor about which of those is right for you. Which ones do they do? Why do they do them? There may be reasons why for one person or another this may be a better or worse approach. The bottom line is people are going to do well if they go through it with a good surgeon that we have, the surgeons we have. They're going to take you through the process. We're going to take you through the rehab. You're going to do great. At 3, 6, a year out, the approach really doesn't matter so much. But as much as it matters that you go through the process in the right way. You're going to pick your doctor because that's the right doctor for you, and they'll take you through what the best option is based on your particular anatomy, what that hip looks like, and why they would do a certain approach. So there are benefits to each of those, but I will let you guys talk with that through your surgeon. That alone is a whole nother talk, again, that I do not want to give. But either way, down the line, people will do great with each of those. Here's a posterior approach. Here's the incision here. So you can see this here. And this one's maybe a little longer. There are different sizes of these depending on what they have to do with your particular anatomy. But this looks good. This is kind of glued shut. You don't see a lot of redness. You don't see that spreading out an inch or two on either side. You do see just below that, kind of between the incision and the green line, you see that yellowing, that bruising. Then pretty typical. If you're sitting, the blood's going to pool down there, and as we get bruising, it'll be down here. Not because there was damage here, but just because that's where the body broke that material down. So that's kind of what that looks like post-operatively. And you can have that in slightly different angles as the previous slide kind of here shows. But that just happens to be one of the posterior approach. No matter where we start, no matter what approach, no matter what process, if we go home or right to outpatient, we're going to focus on walking early. They're going to get you up the same day and get you standing and get you walking. Early, simple range of motion is going to improve your balance, your ability to walk, your ability to stand. The first time they tell you to get up, you're going to think, boy, you're crazy. I don't want to get up yet. But you will be fine. The hip is a very stable joint and you will do well. Just mind the precautions, which we'll talk about, and you'll do fine. But it can be a little intimidating the first step, but you'll realize pretty quickly you're going to feel pretty stable with this. Again, working on that early activity and moving little bits throughout the day is going to help you ultimately reduce the pain. People often come in like, oh, I'm afraid to do therapy, it's going to hurt. And then we do a few things like, oh, actually feels good to move. That's the approach we should be, right? There's always too much. Look, I always want the Price is Right approach. I want to get as much activity as we can that's going to build us up without going over. Going over in this case means we're sore, we're irritated, we're inflamed. It takes more than a day to recover. All those things are not places we want to put you. Early on, we just had a hip replacement. Don't underestimate how big a deal it is to get a whole new hip put in, right? Though there are hundreds of thousands of these done a year, it's still a big surgery, right? So we want to make sure that that tissue over time, the first couple of weeks, we don't need to do a lot. Just get you up, get you moving, do some basic activities, and we'll do fine. Over time, as your hip's ready for more, as that tissue's healed, we'll build that up. But it's normal to have some stiffness. The other thing that changes really quickly with time is if you sit, you're going to be stiff again. I feel pretty good. And then I sat down for an hour and you're like, oh my God, I'm so stiff again. Totally normal, just a normal part of the healing process. That stiffness will get better. It takes me 5 minutes to get going in the morning. It takes me about 5 steps. And then you're like, oh yeah, I got up and I was fine. Over the first couple months, that swelling, that stiffness will decrease pretty steadily, but it is normal as that healing improves and that strength starts to get better. But know that that's a normal part of the process. Precautions. If we're doing a posterior hip, the classic restrictions that have been there forever, don't flex the hip past 90 degrees. Don't bend forward at the waist. 90 degrees, what's 90 degrees? It's the edge of a square, right? It's anybody who had to take geometry, right? Right angle, right? Exactly 90 degrees. We're not going forward past that. Next slide shows some other examples. We're not crossing the legs. Crossing the legs puts a little pressure on the posterior aspect of that hip and that capsule. We don't want to do that. We don't want to rotate. This guy shows his foot turned in there. We don't want to turn or twist or pivot on that planted leg, right? We don't want to twist and rotate. All of these increase the risk of a dislocation in some cases. And again, I will just share with you, I've been doing this almost 24 years. The risk of that is so much less now than it used to be. The hips are so much more stable. The process is so much better. You see less of this, but we still have to respect the tissue. the physician will give you his guidelines of what his restrictions are. Classically, these have always been like 6 weeks of restrictions in the posterior hip, and a lot of people still keep that to some degree. But the risk of this on an absolute scale is so much less, but we still have to make sure we respect that tissue. Don't go around twisting and bending. That's when bad things can happen. When we talk about bending past 90, that means bending down to shoes, bringing your knee up to your chest, doing a big stretch. Oftentimes, one of the tools we'll get at home is have slip-on shoes, or having a little tool to assess getting socks on, because bending down and throwing those socks on breaks that precaution, right? So that's why I threw this one on here. This was the classic one that you'll see. For an anterior hip, the restrictions, as you might guess, are a little bit opposite. Don't overly extend the hip. That puts stress back on that anterior capsule, the approach they came through. And again, same thing here, don't pivot or twist on that hip. Those both will give you a little more difficulty. What kind of exercise are we going to do post-operatively? You're going to come in, they're going to get you up and walk in. Then what are we going to do? We're going to start doing some quad sets and some glute sets, basically some isometric exercises. Tightening up that thigh, squeezing that muscle, usually doing about a 5-second hold, and then relax. Doing the same thing for the glutes. Getting this glute to fire, squeeze that glute, squeeze those cheeks together as hard as you can, and then relax. And that'll be hard to do because we just had surgery and that tissue might be a little tender. But that's the point of this, to wake it back up a little bit. And then doing like some simple bridges. Why do we do these? Well, this is what we need to do to get in, to move around in bed, to be able to lift ourselves, move ourselves around, to help roll over. So these are some of the simple things you'll start with. And they won't seem simple at first. The first few days, they're a little sore. It takes some time, but they will get simple as you go along. Doing some simple range of motion, doing some heel slides, moving back and forth. You don't do like a lot of straight leg raises, just lifting that leg up. We really don't want to irritate those hip flexors. But we do want to move these things in a graded and appropriate way. Sitting around, straightening out that thigh to get the quadriceps to work a little bit. Then once we get going a little bit, we'll start doing some little heel raises, up and down on the toes, get the calves working. Doing our hip strength, kicking that leg out to the side, hip abduction or hip extension to get the kick back. We'll start little mini squats. We'll often then progress to doing some standing and balancing exercises. So we'll talk about a little bit of our balance work. But this is kind of a gentle progression that everybody's going to go through over the first couple of weeks, first few weeks, depending on the time. Some physicians will have you in, again, a few days afterwards. Some people say just do some walking, let that hip heal for a little bit, and then start on these things. And that'll be fine. What's important early on? It's important early on that we're just doing some regular walking and weight-bearing activity. It's very beneficial. You'll get a long way just doing some walking, but the strength, it'll be beneficial for your strength, managing your pain, and just your overall function. If we're moving regularly, you won't get as stiff. You'll feel a little better. My friend Greg Glayman, who is in Canada, always calls them movement snacks. I want little snacks of movement throughout the day, right? Break up that sitting too long, standing too long, doing anything too long will just it was not quite ready for any one position for too long. So break it up with some movement, simple exercises. Balance, really important. Spend time in standing, getting your exercise, getting your center of gravity back. Oftentimes we've just been accommodating for that hip. So we might have been tilted right for left for 10 or 15 degrees for a little bit to account for that hip. That hip's been painful. Well, now all of a sudden we're back to putting weight on that hip and it feels off. We're just not quite sitting right. Give your time for your what we call our proprioception, our sense of balance in space, our sense of where we are in space to get used to that new position. It's a better position ultimately, but it's just not what we're used to. If we spend all this time over here and all of a sudden we've gotten tilted upright, it can make a big difference. It can feel just a little off. So giving yourself some time standing, balancing will help that. And again, also obviously just reduce the risk of falls. What's our progression look like? Over time, we start walking more just to get more endurance, start striding that out over a longer period of time. We'll progress from doing our kind of step 2 pattern, where meaning what early on, they'll have you just stepping up with the opposite leg, just kind of stepping up, going up with the good, with the step, just going one at a time on that step, kind of one step. We call that a step 2 pattern. But you'll go up with the good leg and then you go down with the bad leg. When we get to outpatient, as you start to feel better, we'll start doing steps more normally, more step over step, just like we'd normally do. We'll start with smaller steps and we go to bigger steps. We'll practice our balance. We'll change direction, making sure we can turn comfortably. We're not pivoting, but starting to turn, making sure we negotiate whatever things you're going to come across. If I have to do a certain thing for work or life, negotiating curbs, escalators, a train, a bus, whatever that may be. We want to make sure people are in a position to do those things. So we'll make sure we're building it up to the point where you can do that. And again, those are typical things that people usually do very well with. What are my goals? I want somebody to be able to walk independently, steady, level, smooth, no big deviations. And depending on where you were beforehand, that can take a while. Some people have really not walked with a kind of smooth or steady gait for a while. So it takes time to get that back and kind of everybody to kind of find their level. But we do. It just takes some time. People often think about, well, I had surgery 4 weeks ago. Why am I not better? That's not the right way to think about it from a strength perspective. From a strength perspective, what you need to think about is, all right, I've been fighting this hip for 9 months or a year and a half. I've got to make up some of that time. And if you look at it from that longer lens, it's okay to realize that it might take a little longer to get some of that strength back. And we'll talk about how we do that with our walking in a minute. But I want to be able to negotiate stairs at home and in the community effectively. Wherever I want to go, I need to be able to make sure I can go up and down stairs, not just if I got both railings, but with one railing or no railings, and make sure we're safe and independent. Move from a walker to a cane, and then ultimately to no assistive device at all if we're safe and ready to do that. Some people have been on a walker for years. They get their hip done. They might still be on a walker, but they're going to be doing it with a lot less pain. Most people, though, we're trying to get back to walking without an assistive device. And finally, just make sure we can take care of all our self-care items at home. Make sure we can stand long enough to cook, do whatever we need to shop. We can get dressed. We can do anything we need hygiene related at home. We can clean, take care of all the tools to make sure everybody can still live a safe and independent life as much as possible. That's goal one. Long-term goals, yeah, we want to make sure we get back to whatever higher level activity. But first baseline goal, let's make sure we're safe and stable at home. How long am I going to use a walker or a cane? I have a lot of people come in and say, you know what, I'm gonna ditch the cane. It's gonna hurt me. I don't want it to become reliant on it. I think that's the wrong approach to think about. I don't want to throw the cane away and then walk around with a terrible limp where I'm leaning and I'm lurching and I'm not steady and I'm having more pain. If we're doing that, we don't have the strength fundamentally to walk without the cane. So I want to walk with the cane or with an assistive device until we can do it without a limp. We're going steady, smooth, with a good rhythm. When we can do that, all right, good. Now let's start to use the cane a little less. Let's start to take the cane away and walk a little bit without it. Oh, I can go 2 blocks. Great. That's where we are. Then you can always take the cane with you and use it for the last half of the walk if you want to go a little further. But it does us no good to throw that away and then practice something that's just not practical for the long term. So when we do that, just respect that it takes some time. Wherever that needs to be, let's make sure we do that. It's better to use that to level you out than throw the cane and walk awfully with a limp. As the strength improves and the endurance improves, the quality and the endurance of that walking will improve. One thing that often people will talk about is, I got one leg that's longer than the other. And my answer to that almost always is, okay, I totally get that you feel that, but let's walk through this process. That's not usually the case. Our doctors and all doctors that do this know what they're doing, right? They're taking extensive x-rays. They're looking at everything beforehand. They are making sure they got the right size and angle of that hip to make sure it's perfect for you to match what's going on. But what's really going on? You might have had a slightly shorter leg before. Remember, we looked at that x-ray. We saw how that hip degenerates over time, right? So you slowly lose a little bit of length in that leg, slowly lose a little bit of height. You start compensating in certain ways. That slowly happens. It's a long process. We don't really realize it's happening. Well, what happens? Now we've changed the hip back to this optimal alignment, but we did that all at once, and it can feel like a big change. That ultimately is a better alignment, but it feels very off. So it's going to be more limited for people, especially if they have bigger deviations or have been fighting this for a longer period of time. It may take longer to feel a little bit normal, but the more you walk, the more you stand, we work on balance, we work on shifting our weight, the body will kind of find its own level. But we just kind of have to kind of rewrite that internal map that tells me this is my normal position. Well, it's not. Now we've got back to a much better position, but it does take some time to get used to that. The leg length is really rarely the issue. They take extreme care to make sure they get you right to the right spot. But it does take some time for that soft tissue around, right? We fix the bone right away, but the muscles, the surrounding tissues around them, the muscles in particular, take a little while to get used to that new position, and that can lead to a little soreness initially. But again, that's one of the reasons that the walking and standing stuff at the appropriate level is such an important part. It helps you kind of level things out. Long-term limits. What's our activity like? You know, we're going to have some limitations depending on your physician the first few weeks, 6 to 12 weeks, depending on what they're going to do. 6 weeks or 3 months, they might have some limitations, but long-term, they're going to start giving you more freedom after that time. Start gradually, but as we build the strength, we'll do more. You can build strength all you want, but there still is a limit on how fast the body's going to heal, right? So understand there's our limits that are limits based on how strong you are and how fit you are, but there's also just limits based on human physiology. How long does it take us to heal? How long does it take for that, that hip joint to be really solid, that capsule to heal, for the muscles to build up their strength? There's kinds of limits there. And so that's why we kind of give you some general guidelines in terms of what those limits look like. If you're weaker and deconditioned going in, it's going to take you a little longer, and that's okay. But it can be a little more challenging process, but just keep moving. Not everybody's coming to this from the same spot. Not everybody's at the same place. Some people have really good range of motion, but they're just in a lot of pain. Other people have terrible motion, but they're not in as much pain. So everybody's coming to this from a different spot, a different place. So it does take time to get used to that. And that's what will help you work through. After the first few days and weeks, this hip is stable. We want people to trust it. Spend some time on it, walk on it. That doesn't mean be reckless. It just means spend some time walking, and it will get you most of the way there. Walking will get you most of that, but the strength is what's going to get you in long term. The number of people I've seen that, like, oh, I just walked and I was good. I'm like, great. And then you get down the line 5 years later, 10 years later, I had a hip in, and like, my back hurts or something else is going on. Sometimes it's going, oh, do you have the hip done? Yeah, okay, let's take that. And the hip strength is not quite where we want it to be. So long term, walking's great, but I also want a little bit of a strength and balance program just to continue, because real strength in those muscles takes about 6 to 8 weeks to build up. And if you have a little more strength or a higher level you want to get to, you want to keep doing that for a little while longer. So, but it does take a little bit of time. So respect what the time limit's going to take. You're going to feel pretty good after a few weeks, but optimal functioning means you keep working on balance and some strength for a little while. What can I get back to? Well, golf, usually about 3 months, just due to the big rotation on that hip. The change of direction, the increased speed can take some time. Over time, the joint's much more comfortable with these moves and moves with greater ease. Tennis, pickleball, talk to your doctor. There's some variation in what people will let you do at different times, depending on their approach and your individual anatomy. But generally, with these hip joints, we're trying to limit impact. We're not trying to jump and pound and do those kinds of things on this. We want to make sure that we preserve this hip for the long term. These hip joints will handle motion forever. They are perfectly made, so they will take motion forever. But if you start pounding away on these things, you can start to get some more uneven wear, and they will not hold up as well. Now, that being said, I'm not telling anybody not to do something. That's a discussion for your doctor. You're doing this hip and you're doing these joints so you can live your life. We want to go out and be active. We want to go out and walk and stand and move and do that stuff. But there are some limitations that you might have long term. But in general, people can be very active on these pretty well. Would I want to go up and start taking up heavy impact jiu-jitsu? Probably not a thing you want to do at this point, right? But the motion, things like bike riding, tennis, pickleball, generally are tolerated pretty well. So, okay. That is the most common questions I get. I want to thank you for having me here. I'm happy to take on some more questions. I'm sure there's many things we can touch base on, but I definitely want to see what else is out there. But those are the things that I get most commonly as I think about this.
Okay, awesome. Thank you so much, Kurt. That was fabulous. All right, so we had a few questions, and of course now more are pouring in. You mentioned about a walker and a cane. So someone is asking, initially, will I need a walker?
Some people will use the walker, right? Usually the walker is really short-lived. Some people, it's just a couple of days. Some people get to a cane right away. What I usually have people talking about, talk to people about when they do this, for something that's that short-lived, and even a cane is not something you'll have super long, but that you'll spend most of the time with a cane. Your township, your lending closet, those kinds of things. In Schaumburg, it's at the township, and Des Plaines, you have the Frisbee Center. They have great process all over, almost every township or library or your library of things has a walker that uses short term. So oftentimes that will be something you're using, but it's usually just for a few days. It's a really short term thing. So, but I would say a lot of people are on that for a few days. Again, depends on where you are, preoperatively. So.
Great, thank you. Okay. How do you manage stairs? You mentioned a little bit about practicing on stairs. So you go through that in therapy with people, right?
Yeah, we usually talk to people about that preoperatively, and then we do some work on that, and they'll make sure they do that at the hospital afterwards to make sure you know what you're doing. But yeah, typically what you're doing is you're going kind of up the stairs, up one step at a time, with the good leg. So if I had my right hip done, I'm going to go up with my left step and just kind of bring my right up to meet it. Go up with the left again and bring the right up to meet it. I'm going to use my cane or a railing there to hold me up. So it's not usually that bad. We're just not trying to do the first few days a lot of heavy steps on that leg. It's just not going to have the power to right away. And as that normal inflammation calms down, doing those steps becomes a lot easier. But you'll do one at a time, going up with the opposite side. On the way down, you're going to go down with the bad leg first, because that leg's in the air. It's not bearing any weight. And then you're going to lower yourself with what's the good leg, right? And I don't like the good leg, bad leg. It's a good way to remember it, but pretty soon that leg that's bad is pretty darn good. So you're going to go up one at a time with that left, and you're going to go down one at a time with the right, and using that leg. The leg that's on the ground, your good leg, is the one that's got to do all the work, whether that's powering you up or lowering you down. So
great. Okay, thank you. This is a good question, I think. Does it make sense to have PT prior to surgery, especially if it's a long wait time?
Yeah, a lot of the times we have people doing preoperative appointments, often just one. If you're talking to a physician and you've got a lot of issues beforehand, or you have a lot of concerns, or you've had some limitations for a while, I do have, often with the physician, they'll say, hey, I'm concerned about this, that I can't do this. They will sometimes send you in, hey, let's just do some, do a little prehab, right? Come in before and do some preoperative therapy. It's usually just a short course to teach you how to do some things, build up some strength, and when you go to get you going. And if you do have a longer window, that can be a useful thing to say. I think, yeah, it's a good point. For a lot of people, they know what this looks like. It's not a super long window. We'll have your one preoperative appointment where we'll talk through that pathway again, make sure you're good with, how to use a cane, make sure you get any assistive devices you may need at home, and get you back on track. But yeah, if you've got some limitations and you got a long window, yeah, it doesn't hurt to have a little bit of exercise to do preoperatively. Build the strength up as much as you can. Now, some people have limitations where I just don't have the ability to really recruit that hip or do a lot well with it. And so that may not be as useful. But yeah, I think any mobility or strength you can get beforehand prepares you, I think, is helpful. So
great, thank you. Okay. Do you know, is it normal to feel the prosthesis while lying on your side?
It's a great question. With knees and hips, everybody goes, I feel the prosthesis. Now, yes, you do, because everybody says that. What you're really feeling is, a lot of that just stiffness and soreness. Again, the metal joint doesn't have any nerves in it. You can't really feel the prosthesis, but it often feels very raw to be on that side. It feels very sore. The same thing with the knee. I feel that knee in the middle of my knee when I get up and do the knee. All that dissipates as you go. But yes, it is very normal to feel just a little bit tender and sore on that side. You don't want to be on that side a ton early on, but you don't want to avoid it forever either. You have to start when you're ready. You're like, oh, I'm feeling pretty good. I'm gonna start rolling on that side a little bit, doing a little bit more there. That's really what you're feeling, is more of that soft tissue. You've got that, all those muscles I showed you. And that's why I pulled that side up, because it's just so much soft tissue there. And again, if you're a little thinner and you don't have quite the same padding, it becomes often a little more intrusive. It feels really bony, and it's just really tender and sore. So yeah, it's not really the prosthesis you're feeling per se for those reasons, but that is the experience you have. And so that's definitely what it feels like. It's like, man, I feel this hunk of metal in there. It's really just your tissue getting accommodated to all that stuff and the pressure of being on that, because the hip is really deep in there. But yeah, that's a very common experience. And again, you don't want to do it too early, but I've had people like, I don't even touch that area. And then they have, you can develop some weird chronic sensory stuff if you don't ever touch it, or you don't ever roll on it. I just avoid it forever. You don't want to do that either, but you just gradually, just kind of a graded exposure to that touch, that sensation, to pressure on that side. And your kind of body type makes a difference too. If you get a little more padding there like I do, it doesn't hurt nearly as much. But if some folks just are a little thinner there, and that it can feel a little tender, it's definitely a little tougher for some folks. So a little bit of padding, a little extra padding on the bed definitely helps.
And is that something that just will go away with time as well?
Yeah, that's rarely something that's an issue long term. Yeah, no, it generally is there. You know, in the knees we talked about like how for some people it's occasionally really hard to kneel for a long time. This is less common than that, where sometimes you're mostly pretty good, but occasionally it just takes a little longer to get comfortable with being on that side. But yeah, that's rarely a long term issue, I find.
Great. Thank
Most
you.
time when you're laying down, you're also not on a hard surface. You're on a bed, you're on something cushioned, right? Like just the nature of that means it's a little less common.
Got it. Thank you. What do you recommend for showering during recovery?
Yeah, the shower chairs that people throw in. Obviously, it's nice if you have no barrier to step over. You don't have to step over anything. Just from a safety perspective, you gotta just walk in, you know, like a walk-in shower or something. I have seen a lot of things. A lot of times, people will rent the shower chairs or get one from the lending closet. Recommendations vary across the organization. I've had people grab a plastic chair from Walmart and throw that in there. Like, I don't have a shower chair and I couldn't get one, and they will get that plastic chair from Walmart and sit in that, and you're like, okay, well, as long as it's sturdy enough for you, you know, you just want some place where you can sit down and you're not standing in a slippery surface where you can be, you know. Some people will have people put in like a little handhold for extra safety, but most people don't have to do that. But yeah, that can be a challenge. But yeah, there's little shower chairs you can put in there that are part of that pre-operative packet. If you think that's something you need, there are options to get those kinds of things. Or if you have a really low toilet seat, like I think I mentioned briefly earlier, that's also something for your bathroom. If it's getting down too low with a posterior hip, you might be breaking that 90-degree rule a little bit. So being elevated, just an elevated seat above that is something that's often people will do as well. So those are the most common things. Yeah, shower chairs, that's a great question, because that's one of the other pieces that sometimes people will get. But I've had people do the Walmart version, and I thought that was pretty clever. It was like a plastic chair. It was $9. It worked great, and I didn't ever need to worry about it again, you know.
Awesome.
Better
and
than,
with regard to those
$300 shower chair you're never going to use again, right?
Right. You'll end up donating it to the lending closet. Yeah.
Yeah.
And how about those elevated toilet seats? Do you want them to gradually get rid of that over time, though?
That's usually just in terms of that first 6 weeks when you have a precaution. So that's something that if the physician says, I want you to keep these precautions for 6 weeks, then that's something you'd have for a little while. Yeah.
Yeah. Got it. Okay, great.
Yep.
How long before you can submerge yourself in a pool post-surgery? Do you know the answer to that question?
Yeah, as long as usually just because of getting in the pool at the first 6 weeks because of those precautions, but usually it takes that long for those incisions to totally heal anyways. But generally you're going to be pretty safe. Once those incisions are healed, fully healed and closed, you're good skin. Before then, the places like a pool, definitely a hot tub, more risk of infection, those kinds of things just you would have in those areas. So they're going to ask you to stay away from that kind of stuff for a little while. Usually after 6 weeks, that's when I tell people, if you want to go do this again, ask them now. You're healed, you're closed. Ask them if you feel like ask your doctor if you feel like that's an okay time to do those things again. So I know some people want to do that. The other thing about like submerging, like in a tub, that's fine. That's your own place. But you know, in a pool or any of those places, you're talking about slippery environments too. So there's just a little bit of safety. But again, that's why I actually say generally 6 weeks, we know our incisions are healed. We know our precautions are gone, which makes it easier to get in and out of those places, and our strength and functions getting better. So risk fall, slipperiness is less of a risk. So I would say that's generally the guideline I have in my head.
Great, thank you. Okay. If you live alone, is that an okay thing to do after surgery? Can you just go home and live alone?
Yeah, I have lots of people that have lived alone and done that. Again, a lot of times, especially if you're on one level or you can be on one level, a lot of people are totally fine with this. It really does just depend on any other medical issues or challenges there. Is it good to have somebody else there the first couple days just to be sure? Absolutely. I think that everybody's more comfortable if hey, I just don't know how I'm going to respond to anesthesia, that kind of stuff. At least a couple days is great. But after the first couple days, it's a lot of people are safe and independent. But it's good to just know where your contacts are, know you have some other people in place. But yeah, no, lots of people have done it, but know where your resources are. I think the bigger challenge is, you know, if you're not driving, right? If it's you're not allowed to drive right away for whatever reason, like your driving would put you in a place where you're breaking your 90-degree rule, or you just don't have the ability to do so. Then that's a more of a challenge. So you might need to get an Uber or catch a ride. But being independent, being able to make sure if you have to go home and be alone, they'll make sure you can stand for enough time to, make a sandwich or cook a meal or get around your house. Your environment is such to there. And then you're going to want to ask those questions beforehand too. What else do I need to make sure that I can do at home beforehand? But yeah, lots of people have done it. But you just ask a few different questions. That's one of the things we always talk about preoperatively.
Gotcha. Great. Okay, we've got a bunch of active people here.
Yeah.
Wondering when I can lift heavy things like 50 to 100 pounds.
Great question. Usually after 3 months, they're going to keep you a little limited from going super heavy. There are, especially if you're younger and you're active, they're going to do like what they call a cementless hip in most cases. There's where the bone's actually going to grow into that stem that goes down into the femur. And in those cases, they're probably going to limit something heavy for a long time. I don't know what everybody does for an absolute weight limit for a long time. Often they'll tell you you're not going to do over 50 pounds for over 25 or over 50 pounds for X amount of time. But long term, again, are you going to want to go back squat super heavy? No, probably not, because you're going to load that hip up and, a little stressful. But you can make accommodations. You can work around it, do your seated leg extensions and curls. But yeah, if you got stuff you got to carry, usually there's a limitation for a couple of months in there that they'd probably put you on, just to make sure. Because if you are younger and healthier, you're more likely to have that cementless stem and that bone's going to grow in. And at 3 months, that's in a much better spot. So.
Great. And is that about the same for like picking up a child? Like a 20-pound child? There's somebody who's asking about a 20-pound child. When can I pick my grandchild up or child up?
Yeah, grandchild up, child up. If you have to do that, yeah, absolutely. You're typically not doing that for the first 6 weeks just because they're wiggly and they're heavy. But no, you can sometimes do that a little bit sooner. 8 to 12 weeks, I would say, is generally there.
Okay.
Yeah, it depends on what you're gonna do. If you got, again, if you're a little more fit beforehand, but if you just have to watch how much you do. Some people are totally comfortable with doing that right away.
Got it.
But you still want to be careful with like twisting, pivoting, that kind of stuff more so. Straight line movement, picking up, not as challenging as, I got to twist and move this kid over here as they're wiggling around.
Fair enough. Great. All right. What's the time frame before swimming in the ocean? Is that about the same as getting in a pool?
Yeah, because it's really just about safety and then skin healing, right? Once the skin's healed and closed and everything's good and our risk of infection. Look, if we manage dislocation, which is, let me tell you, so much less than it was 20 years ago, 25 years ago when I started doing this. They're so much more stable, such a better construct. And infection, which is it's just a risk anytime you're cutting into the skin. If you manage those risks the first few weeks, you've solved most of the problems you're going to have. So once that skin's closed and healed, the ocean's not any different. It's just about making sure that it's closed and we reduce our risk for infection.
Great. Okay.
And you get stung by jellyfish.
Yeah, that's not too bad. So you mentioned a little bit about driving. Someone's asking, when are you able to drive? And is there a physical therapy test you would have to be able to pass in order to be able to drive?
To be able to drive, you have to talk to your doctor.
Okay.
That used to be a strict 6 weeks all the time. That's less so now. Some people will let you go sooner. You have to be not on pain medications, which would otherwise preclude you from driving. You have to be able to move from pedal to pedal. And again, those aren't the highest bar. Most people don't have a ton of pain, and the movement in there is a little bit more. But the physician's going to clear you to do that. It used to be everybody was 6 weeks, and that's less the case now. Now they're like, no, if you're fine, if we don't have but if you're in like a low car where you're going to be really bent and flexed at the hip, they may say, no, you can't do that. But so many people have like sitting up high in a SUV where you're seated very high, you're not flexed forward at the hip. But yeah, you can't be sitting in a low seat that would otherwise put that pressure on the hip if you have that posterior approach. That might be a limitation that people have. So
okay, got it. So maybe they could even do something like a little pillow or something to sit on, some kind of a booster or something.
Yeah, being in a higher car, being in a booster, and then talk to your doctor, because that does change a little bit from place to place.
Great. Okay.
It used to be, like I said, it used to be a lot stricter about, making sure you're not driving for 6 weeks, but that's not typically the case anymore.
Great. How about sleeping positions? Do you have recommendations for sleeping positions?
You're going to be on your back to start with, which I know not everybody's favorite. You're typically not laying on that side a ton the first 2 or 3 weeks. It's just really uncomfortable, and then gradually you can start doing more of that. They used to have the big pillows between the legs and all this other rigmarole. Again, less of all those kinds of restrictions that we used to have. But no, gradually starting on your back, gradually then being able to roll from side to side. You might have a pillow between the knees as you roll from side to side, just for comfort, because as you're on your side, if that's hips on top and it kind of sinks down, you might feel a stretch across the top of that hip that might feel a little bit uncomfortable. On that side's less comfortable, but you're mostly on the back the first 2 or 3 weeks to do that, and then gradually start changing some positions to that opposite side. And again, I say this knowing that the hardest thing I can do to somebody is tell them you have to sleep in this position if their favorite position is something else. It's really disruptive to sleep, right? I've had somebody the other day, like, how do you like to sleep? And they're like, with my arm above my head like this. I'm like, well, you're in the sling for the next 6 weeks, so that's out. So what's our next best position? Can we sleep on your back? Can we prop some pillows under that guy, right? So I understand that that's often one of the things that makes the recovery hard, is just if you're not your favorite sleeping position, it can kind of stink for a little while. But spend a couple of weeks, let it recover, and then gradually you can start to move to some more of those positions. But by 6 weeks, you can go where you want, and it's perfectly fine. So, but they're going to keep you on your back for a little while.
Got it. Okay, good to know. We had a few people ask about that, so that's helpful.
Yeah.
Okay, someone's asking. Question. Yeah, with regard to the shower, I think they're talking about the incision recovery. How soon after surgery can I shower? I think it's less positional with the chair. There's another question.
Yeah, good question. They might give you some people will have them wrap that and then just put a wrap or a cover on that as they do it, and then you can get in the shower and say, you know what, for the first few days, just soap and towel, and then at point X, like 2 weeks out, I can get in the shower. You can wrap it. With some of those glued ones they have, they're like, you can get in the shower at 2 or 3 weeks and don't scrub it, but just let the water run over it and then pat dry. You have less people using some of those staples and that kind of stuff now, and more like the one I showed you. So it will depend a little bit on those things. And again, anterior, posterior might be slightly different, but yeah, you get in the shower. Most of the time after the first few days, they're like, all right, it's starting to heal. You can get in the shower now and let the water run over that, and then just pat dry. So it's usually not too long. It's just a couple of weeks typically, I believe.
Okay, great. All right.
I'm not sure how much variation there is in that one. That's a great question.
Yeah, and that may be a question for their doctor, right? Because the doctor may.
Yeah, like I said, I know there's variation, but I thinking about where, I'm not sure where everybody's at with that one, but there is some variation with that, especially with those glued ones. They're like, nope, you're good. Cover it up for the first X amount of time, the first week or two, and then get in there and just let the water run out of it. Don't scrub it and let it pat dry, and those are good. You'll see more of that typically being the case, just covering it at first. Just again, these are all about infection risk, right? So
right, exactly. Okay, let's see. So here's another one. Physical therapy will focus on rehabbing my hip. When can I start upper body workouts with their personal trainer, for example, sitting in a chair, like holding 10-pound weights, etc.?
Oh, great question. That's a good example too. Yeah, you wouldn't want to do stuff standing where you're loading the spine, because if you're thinking about standing and doing stuff, you're going to put load on that hip as well. But yeah, if you're sitting, you want to do lats, rows, some of that stuff. You talk to your doctor, but they'd probably give you a couple of weeks, just because you want to devote that energy to rest, recovery, other stuff. But I've had people come in and they have some shoulder and neck issues, and I'll have them sit there and do some banded work or some row work, just to kind of help with that posture and strength if we need to. So there's not an absolute limit early on. I would just say, where do you want to devote your time and energy? There's a certain amount of focus you want to have on just what your hip stuff is. But if you're sitting and you're not loading the hip per se, like you would be with a standing exercise, you can do some upper body stuff pretty quickly. But I would just encourage you to get through that first couple of weeks and make sure your energy is focused in the right area. But yeah, there's not a huge limitation in that. You could technically do sit and do lats or rows, or do some band work or bicep curls, and you're not going to impact the hip really at all. If you're standing, you're going to impact it a little bit more, because that body weight, that weight's coming through your body weight into the hip. But if you're sitting, there's really not a whole lot on there. So there's some, but I would say you want to give it a few weeks before you start cranking away at that. You can do some little stuff to kind of minimize that loss of tone, and if you've been working on something. I've done that a lot with people, but yeah, don't feel like the need to get there. There's, as good as your recovery is going to probably be, like, yeah, devote your energy to the right places.
Yeah, fair enough. Good. Okay, and one last question. How does IBJI physical therapy, outpatient physical therapy, differ from the hospital-based therapy programs?
You know, I've been in IBJI for 24 years. I haven't spent a ton of time in the hospital systems, but what I'll tell you is, you know, one of the things that we do is we're going to work together with your physicians. We work coordinated with them. We have the ability to communicate with them at a high level. We know a lot of their protocols, so I think there's an advantage there. In an outpatient setting, you're going to be around a lot of other people that are pretty fit and pretty active. In a hospital-based setting, that's not always the case. So I think you're working with in a nice space with good equipment around other people that are active. And I think I've talked to a lot of people about this over the years, and people like coming to be in our space because they get to be around other people that are active. There's a camaraderie, there's a activity level in the clinic that is generally pretty positive, and I think that's beneficial. When you're around other people that are doing that same work, I think that helps. So I think that's an advantage in those cases versus, you know, maybe being in a hospital setting. Yeah, it's a busy space, but sometimes that can be good. It can be inspiring to somebody. Ooh, I want to move like that person, right? And I think you want to be out there and do those things. Yeah, I think that's the thing that people have said to me that they enjoy the most. So
great, awesome. Well, thank you very much. We've hit our 8 o'clock, and I hate to keep you beyond the time frame that we've dedicated. So thank you so much, Kurt Hutchinson. Thank you all for joining us this evening. Fabulous presentation, great answers to our questions. We appreciate your time, everybody. Have a great evening.
Good night, everybody. Thanks for coming. We appreciate it.